Engineering there, and Temple University School of Medicine in Philadelphia. He was also born in Philadelphia. His first residency training was in emergency medicine, an experience which persuaded him to pursue a career that allowed more hands-on patient contact. He decided to switch to family medicine and earn his board certification in this specialty. Dr. Coleman spent his first year of practice in Kenya and Sierra Leone, Africa. On his return to the United States, he provided primary medical care for 9 years to the Menominee Indian Reservation in Wisconsin. Did I get the name right, Jeff?
Pretty close.
Thank you. Moving east to be near family, he established a community health center in Montrose, Virginia, providing primary and preventive health care with regular house calls and to patients. He continued his passion for direct patient care and for home visits when he moved into hospice work by starting a practice focusing on home visits and palliative care in 2004. He served as its medical director since 2007. Dr. Coleman has practiced hospice and palliative care exclusively, and he's certified in palliative medicine and family medicine. He has been with Montgomery Hospice since 2007. It's a great pleasure to welcome him. And our other panelist is Ms. Cornelia Strong. She's our Vice President of Strategic Development. Cornelia is a registered nurse with 23 years of nursing experience, 9 of which have been in hospice clinical management. She obtained her bachelor's degree from the City University in London. She's a certified hospice and palliative care nurse, and she's currently pursuing a master's degree in healthcare administration. Cornelia was born in Sierra Leone, Africa, and she has been in the U.S. since 2003. Cornelia's main focus has been medical, surgical, and community healthcare, as well as end-of-life care. During her 11 years at Montgomery Hospice, she has developed and fostered good working relationships with healthcare partners and actively participates in community education events such as the one we're having today. Welcome, both of you. The main objectives we have for today are 3. We're going to discuss the best methods of approaching advanced care planning with African American communities, and we're going to identify barriers, but we're going to classify these barriers as far as we can into the barriers that are present for recent African Americans that immigrated to the U.S. and African Americans who have been in the U.S. for many generations. So we're going to look at similarities and differences in both. Moving to our first question, and before I go into that, I want to encourage the participants to post their questions on that chat box that is at the left side or right side of your screen. So please, if you feel that something needs clarification, type your question right there. Our first question for today is, what is advanced care planning and why is it important?
Well, advanced care planning are the decisions that need to be made in case some serious illness would occur with the person. And so this is the decisions and your discussion with your family or friends or whoever is important to you about what you would want done. If you are unable to make decisions for yourself, or even if you are able to make decisions for yourself but want someone else to do it for you.
And it's very important that that advanced care planning takes place, so that when you're unable to make decisions, your family knows what your wishes are, and they're able to follow your wishes, and there's no confusion between family members as to what you want or what you would expect.
So the main goal is to avoid confusion and conflict among our loved ones should we become gravely ill or have a debilitating accident, so that our loved ones know our wishes and can honor them. So can we say that advanced care planning can improve quality of life by avoiding unwanted treatments at the end of life and decreasing the burden and increasing choice for patients and their families?
That's correct.
Yeah, we want to keep families together and not upset because they don't agree on what is the patient's wishes, right?
That's right.
So, when is the best time to have a conversation about advanced care planning?
I think when you have most of your family members and friends together would be a good time so that everybody's hearing the information at the same time. So that when they need to enact your wishes, there's no second guessing. One person would not be saying, "Oh, I thought Aunt wanted this," and somebody says, "Well, I thought you wanted this something else." And usually, we can pick the times. Usually, if we're probably watching television and something comes up about death and dying, that's a concern to us. We can bring that up and say, I would not. This is what I would want when I'm dying, or so that it's kind of eased into a conversation. It's not. It reduces the stress of the moment. Or if we've come from another person's funeral, or one of our friends or family is gravely ill, you can use that as an example to say what you would want or what you would not want for yourself.
So we can use movies or events around us to prompt a conversation with our loved ones. That has happened to me, and that has been very beneficial as to having that conversation. But Jeff, you had a different idea of what would be the right setting for this conversation.
Well, it's very important to have the conversation when there is a non-stressful moment. One of the worst times to have it is just that when someone is in the hospital or actively dying, suffering, those sorts of things. But sometimes holiday situations come up, things like that. Thanksgiving, I sometimes suggest that families get together and actually have the conversations then in order to uh, for everyone to actually know when what needs to be done and when for any particular family member.
So I may find difficult to talk at things even when everybody's cheerful and thinking about happy things. How would you handle that? How would you bring it up, Jeff?
Well, usually waiting for a moment of if there's someone that has recently passed away, perhaps the movie, as Cornelia said, uh, those sorts of things. If there is some opportunity or about birthdays, sometimes you just have to have a formal discussion about what it is that a person would want the
And
oldest
it's
member of the
probably
family.
not only one discussion, but a series of discussions that that we need to have. It's probably an ongoing discussion because what I have seen with my parents is at first they had certain wishes, but when they saw their friends' age around them, they changed their minds. So is this a one-time conversation or an ongoing dialogue?
It could be ongoing, but I think the first time what you want is to give people the permission to be able to talk about these things, to make it, to normalize the conversation. So it's not something that we are afraid of talking about. So it can be ongoing, but the first conversation is giving people permission because it might be that somebody in the family has been thinking about this, but feels that if they bring it up, it might upset their mother or their father or the elderly person in the family. So it's really giving permission so that it could be something that we can talk about and not left for us to guess when somebody passes.
Perfect. Um, do we see a role in the faith community to assist the members in these matters?
Well, the spiritual community is very important when these issues do come up because they provide a lot of guidance for various families and African Americans. Pastors, leaders in the church, such as deacons and elders, may very much be involved when someone becomes ill, and the family may turn to them for some guidance for their beliefs and for spiritual support because it is a difficult time.
So that makes me aware that maybe the faith community needs to know a little bit more about what these treatments are about so they can facilitate these conversations with their congregants as well.
Yeah, I think it's important for the faith communities, the religious leaders, to be aware of the different treatments that people would require at the end of life, and what the benefits and burdens of those treatments are, so that they would be in a position to help support their congregation when they're making decisions as to what they would like in the event they can't make decisions for themselves.
Absolutely. Uh, the more information, the better.
So we are going to use this form called 5 Wishes to guide us today. And 5 Wishes, we chose this form for a number of reasons. One of them is because it's the most used document in the U.S. And the second one is because the language is really easy and it's for all ages, and it kind of facilitates a soft conversation about these issues. But before we go into the first wish on the 5 wishes list, I want to bring to the table some of the barriers to implementing advanced care planning in the African American communities. And I know it's widely known, the trust issue, but I want this audience, which is a wide audience from all backgrounds, to understand where that is coming from.
African Americans have a mistrust of the healthcare system in general, especially recently, because of how it has treated them in the past. There have been issues such as the Tuskegee experiments or Henrietta Lacks, and oftentimes people of color do not get as aggressive or as good a treatment as the dominant culture folks. And so if we start talking about advanced care planning, it sounds like we may be taking something away from them that other people may get. It's like giving up.
Do you want to talk about how is this different or similar for African Americans who are new to this country or just immigrated, who don't have a long history with the healthcare providers?
For the most part, African Americans who are new to America do not have the trust issue, because they did not, their generation did not relieve the issue with regards to trust that the African Americans of previous generations had to go through. So that usually is not a problem with the African Americans who recently came to America. However, the similarity here is that African Americans, recent African Americans, do have a problem with Advance Directive also, because they too want to explore all the treatments that are available to them.
Yep. So are there religious concerns with some treatments, such as feeding tubes and food?
Well, some African Americans believe that really God is the person that's in control of whether you live or die, which ultimately is the case. And so some folks may believe that we need to do everything possible to keep the person alive and well, according to the will of God. And so they may pursue more aggressive treatments that may be actually more of a burden to them or cause more suffering.
So it's imperative that when these discussions happen in the healthcare realm with patients and their families that these conversations are fully transparent and it allows for discussion of benefit and burdens of each treatment, right? It's a dialogue. So there's a sense of equity as to these are the discussions that we have with everyone. But it's also patients' choice to choose more aggressive treatment if that's what they want, right?
Yeah, I think it's their choice. I think what is important is that they have all the information to make an informed choice. So, if they should know if they choose to have a nasogastric feeding, what are the benefits and the burdens of having a nasogastric feed? And if in the end they decide to have a nasogastric feeding, that's fine. But then the healthcare community has satisfied the requirement that they had provided the information needed for them to make informed choices. What may be the problem is when they do not have all the information and make choices, and then further down the road they want to reverse these choices, as in the case with nasogastric feeding. It's usually a much more difficult decision to stop the feed than to start a feed. So it's imperative that we provide that information to them, and then with all the information they can decide what they would like to do in the instant that they are critically ill.
Perfect. I think we now can move to the first wish here on the 5 wishes. My wish for the person I want to make healthcare decisions for me when I can't. And this much I know about who that person should be. It needs to be over 18 years old. But maybe you can tell me more about the other qualities that we want in this person that we're choosing to speak for us when we can't.
The person needs to be a mature person, of course, 18 years old legally, and that person needs to be calm and have your best interest at heart. They also need to be probably close to where you live, so that if something should come up, that they are available to come and either sign documents, make decisions, talk to your healthcare team or providers, and figure out what is the best thing to do according to your wishes.
I would also add that it doesn't necessarily have to be a family member. It could be a friend. Definitely you want somebody who's not going to be emotionally involved, so that when they need to make that decision, emotion doesn't come into play, and they're able to follow your wishes regardless of what their opinions about your choices are.
So I have heard horror stories about feeding tubes that are put at times when really they should not be placed. And I think we can share some of those.
Yes, I had a personal experience with that when my father died. The physician, it wasn't here in America, but the physicians had decided that he had been unresponsive for a couple of hours, and the decision was made for them to put in an NG tube, and I was in consultation with them via phone, and I was not in agreement with having a tube put in, as I did not feel that would have been my father's wish. However, I was very conscious of family involvement and the influence that family and friends and the extended community have. And I was worried that if I do not agree to have an NG tube placed, that I would be held responsible for his death. That it would be said, oh, his daughter in America didn't want an NG tube placed, that's why he died. However, lucky for me, he did die 2 hours after that conversation without having a tube placed. So even though we have the knowledge, there are other influences that can affect the decisions that we have to make for our loved ones if they do not already have an advance directive.
Mhm.
It is also best if it's just one person making these decisions, although sometimes that's difficult in African American communities where family is very important. As Cornelia just said, a lot of times there are a lot of extended family members that have something to say or are very involved. And so decisions are often made as a group, but still there should be just one person named on the Advance Directive that really is in charge and is the final sayer besides you, the person who is getting the care.
So, from what you're saying, there's more of a reason to have these conversations in advance so everybody knows, so the community can support that decision maker or that appointed person that is going to make decisions when I can make them for myself. And they would all know that that's what I wanted. It's even more important to have within the African American community, the community know our wishes, right?
Yes.
So did we say someone who's nearby or someone, can I appoint someone far away?
We can certainly appoint someone far away, but it's not the best idea. It should be someone that can interact with your healthcare team. They need to be close by. They need to be calm. They need to be aware also of what your decisions are in the first place, because sometimes, and I've been surprised like this, you find out that you are the decision maker and didn't know it, and that just puts an undue burden on you to try to figure out what it is that your loved one actually wants done.
And that's exactly the situation we want to avoid happening, having to make decisions that you don't know what the person may have wanted. That's the whole point why we are talking today. So before we go to our next wish, I want to thank Jane for bringing up that another advantage of using 5 wishes is that it's a document that can move around the country and it's honored equally in the state of Maryland, in the state of Virginia, or in Miami. So it's portable across state lines, and that's another reason why we like this document. By no means are we endorsing it, and I think every person needs to choose whichever document works for themselves. We like the language of this one as well. So the next wish that we have is the kind of medical treatment I want or don't want. So one thing that comes to my mind when we talk about what we want or not want is quality of life.
Well, absolutely. Generally, the type of treatment you want or get may affect your quality of life. We can do a lot of things to people. That doesn't mean that they're always good. So, procedures such as cardiopulmonary resuscitation or CPR, sometimes IV fluids, sometimes inserting NG tubes or PEG tubes for feeding. Some of these things can be very invasive and do a person harm in the long run. And so we need to be aware of those. So knowing something about these treatments is important. I usually say if somebody either is using a machine to help you live or is invading your body in some way, then that's something you need to make a decision about in advance.
This also has to do with the amount of pain that we can tolerate or we cannot tolerate, and maybe that changes as we get sicker. And to me, that defines the kind of quality of life that we're living, because if we're living with a lot of pain, that might not meet the definition.
Well, pain level and pain assessment is individual to the person. So, what the amount of pain that would be tolerable to me may not be the amount of pain that's tolerable to you. And it also has to deal with quality as well, because you may be able to have pain medications that can control your pain in most instances, but as we all know, one big side effect of pain medication is that it makes you drowsy. So somebody might decide that, I would rather tolerate a higher pain level because I want to be awake and responsive for my family. Maybe your grandkids are coming out of school and you want to spend time with them during that time. So you may want to tolerate that amount of pain, where somebody else might say, I don't want any pain at all. Whatever it takes to control the pain, I want the pain controlled. So it is kind of an individual thing, and it varies, from time to time, and where the person is at that specific time, both mentally and emotionally, not just physically.
Mm-hmm. Mm-hmm. So one thing that I want to ask you to do right now in this section is to talk about the different treatments, because we have a wide audience. Just online, we have 63 people here, and talk about feeding tubes. What are the benefits and the burdens, and when should they be used or not?
Well, I'll try to cover as many of these as I can. We'll do feeding tubes first. And generally, there really are only two indications for feeding tubes in someone that is older, that has advanced illness, and that is if you have some sort of obstruction of your upper gastrointestinal tract, like you can't swallow, and you have cancer and you're getting radiation therapy. That may be or some other chemotherapy, or having surgery in that area. That may be an indication for a feeding tube. The other one is generally an acute stroke. Uh, in the short term, that may be an advantage. Sometimes feeding tubes are also used in uh, following severe trauma to provide nutrition, but it varies. Actually, a slightly uh, malnourished state may actually be to your health's advantage in the long run when you get to serious illness, oddly enough. So, feeding tubes, generally for things like dementia, are not indicated, mostly because you would think if you put a feeding tube directly into the stomach, the food would stay down and go into your intestine and be absorbed. But that is unlikely to be the case, actually. A lot of people suffer from reflux, or meaning that the food will back up your esophagus and end up going down into your lungs, in spite of the fact that the feeding tube was inserted so that it goes directly into your stomach. In addition, people that have feeding tubes are less likely to be moved in bed, probably because of fear of dislodging the tube in some way, and therefore they're more likely to have bed sores or decubiti, which can cause them more problems later on in life. Other things that need to be considered, I'll go through things that are on what's called the MOST form, which is another type of an advance directive. And MOST stands for Medical Orders for Life-Sustaining Treatment. On the first page, they talk about cardiopulmonary resuscitation, and on page 2 about some of the treatments you may or may not want. The first one is concerning ventilation. Would you want a ventilator, someone to put a tube in your throat that goes down into your lungs and have them breathe for you? And so how long would you want that done? Is it going to benefit you? Would you want to stay on that until the very end of your life, or would you want someone to withdraw it? So that's one of the decisions you may need to make. Next is whether or not you would want transfusions or not. Would this be something that you would accept? It may depend on your religious convictions. So, and also upon the burden, because you may have to go somewhere else for a transfusion. Let's say if you're at a long-term care facility like a nursing home, they often don't do transfusions there. You would have to be put in an ambulance and taken somewhere else. to a transfusion center or a hospital to get that done. Another issue is whether or not you want antibiotics given. And oftentimes these are intravenous antibiotics, and that means needle sticks, or sometimes special catheters placed in you so that you can get these long term. And not all antibiotics are not benign medications. You can get complications anywhere from diarrhea to renal failure, depending on how much and how long you use them. So it has to be something that's taken into consideration. And oftentimes, when someone is seriously ill and close to the end of life, there is probably little benefit to antibiotics. Another consideration is whether or not you want to have surgery or not for someone. Is that surgery going to benefit you? And it's not only the surgery, but it's the anesthesia that has to be given to perform the surgery also that may cause complications or make you feel worse and give you a poorer quality of life. Other treatments that you need to consider are dialysis, which is when you go and have hemodialysis, you go to a particular center and have your blood filtered of its waste products. And if you get that done repeatedly, usually it's 2 to 3 times a week, most commonly 3 times a week, and it sometimes takes a toll out of you to get that done on a regular basis. So those are the main things that need to be covered. We already talked about feeding tubes and a little bit, IV fluids sometimes can be a problem or something you can need to decide about also. At times, IV fluids may not be the best thing for people because their body may not be absorbing the fluid and it all goes into the wrong place, such as in your lungs, and causes, or your belly, causing you to have bloating, or if it goes in your lungs, it may cause you to have more shortness of breath. So these are some of the issues that are often decided on the most form, which is, like I said, medical orders for life-sustaining treatment, and usually are filled out by the physician in consultation with the patient and or the family, the primary caregiver.
The MOLST is a form of Advance Directive, which is a medical order, right?
Yes.
And it's used mostly in hospitals. Nowadays, everybody needs a MOLST.
Yes.
If you go for treatment. Did we discuss CPR or no CPR?
Oh, I didn't get CPR is another issue, which on TV it is commonly seen that someone gets 5 minutes of CPR and all of a sudden they're alive, awake, and well, and can talk back to you. And that's often not the case. Out-of-hospital success rates for CPR are somewhere around 3 to 5%, depending on what the issues are, meaning 3 to 5% chance of leaving the hospital mentally intact. And so what happens with CPR is the person will be found down without a pulse and or not breathing perhaps. And so someone will start with chest compressions. They'll push on your chest and they may help you breathe. Those compressions, pressing on your chest like that, most of us have seen that, are not benign. Ribs can break. It can cause significant pain, and especially if done incorrectly. Same thing with respirations. Usually that involves eventually putting you on a ventilator or a BiPAP machine, which is a type of face mask that will help to breathe for you. And those can be uncomfortable, and it depends on what you may or may not want. That you have to think about those things and how long that you may want to try to be sustained on them.
One thing that these 5 wishes form has under the kind of medical treatment I want or don't want is what happens if I'm in a coma, or what happens if I have permanent or severe brain damage. And these are the things that whoever is filling out the form can think of the kinds of how do they want, what kind of medical treatment they want at that point. Want to talk about that?
I think that ties in with what you were saying about quality. So, it's what the person, what physical state, what's the lowest physical state that you would want to would be acceptable to you. So, would it be acceptable to you to be in a coma, to be bedbound, to have all your physical needs met by somebody else? Would that be something that you wouldn't mind to happen to you? Would you rather be able to do some of the things for yourself? Would you rather would you want to be able to communicate with your family member rather than be in a coma and not be able to talk? Or do you think, because sometimes people think, especially if it's something that is short-lived, that's why it's very important to have the information. Because if it's something that's going to be short-lived, then, some people might want to tolerate being in a coma for a short period of time. But then you have to think, if it's going to be extensive, is this something I would want? So it's very important that you explore the different options with your physicians and your family so that you're well informed to make the decisions.
Thank you, Cornelia. There was one comment on the chat box here alluding to what if we have appointed more than one person to make decisions for us, and how would that play out? Have you had any experience with that kind of situation? What says, and I'm looking for the actual text here, that if there's more than one person, we need to clarify that. But have you had a situation where there was more than one person appointed to make decisions?
Oftentimes that will occur, that the patient may have appointed all of their children or several of their children, perhaps, to make decisions for them. And that can be difficult if they're not in agreement with each other. And that's why I say that really one person should be appointed to do that, and your decisions should be made clear, because really what it takes at that point is a lot of negotiation among the healthcare providers and the family and the patient, if the patient is involved or not, about what should or should not be done for a person. And that's why it's important to try to narrow it down to just a single person that's available that can do this, can help you. And for that person to know what those decisions are.
Mm-hmm. And this was Sarah Perry saying, if there is more than one healthcare agent identified on an advance directive, it should be termed this person or that person, and not and. Having only one person named is the best.
And I would suggest, even with that you say who's the primary person and who's the secondary person, because so that there might be an instant where the primary person is unavailable, so you probably would want to have another person listed, but I would want to specify who's the primary and who's the secondary so that we avoid that confusion.
Mm-hmm. Thank you, Cornelia. There's another question. Is the most required in addition to an advance directive?
No, most are not required for any individual patient to have them. The hospitals are required to do most forms on patients that they are transferring to facilities, such as nursing homes or to home care. If they're just going home, they don't have to have a most form. Most forms need to be offered on admission to the hospital also, but patients do not have to accept them. Same thing, home health agencies are supposed to go through most forms when they're uh, starting care, and as well as hospice agencies. So these are places that are required to do them. And the thing is, the most form does not have to be permanent. It can be changed at any time or revoked or totally stopped, just as the rest any advance directive can be. But and with most forms, they should also be reviewed once a year, just probably just like your advance directives. Good time to do that is like sometime around your birthday.
I like that. Discussions on Thanksgiving and on birthdays.
I know, it's really happy.
Yeah. So we go to our next wish, and I encourage the participant to continue using this chat box. We have Sarah Perry with the comment here. Most people do not think their understanding of CPR comes from the TV and the movies they have seen, but they have seen that version of CPR hundreds, if not thousands of times that has been imprinted on their minds. Their version on TV and movies remarkably consistent and dangerously inaccurate. Many people believe CPR will be successful most of the time in reviving the person. It doesn't hurt or harm the person. The person snaps right back, and how and who they exactly as how and who they were before the CPR. None of these are true. Thank you, Sarah. That is absolutely accurate. Thank you for that. So we move to our next wish. How comfortable I want to be. And to me, this brings quality of life. And how can physicians and clinicians in general can define a baseline of quality of life for their patients?
One of the things that the physician or other healthcare provider needs to do is to figure out where they were before they became ill. And it's a good idea to probably separate it into two portions. What was your physical level of function and what was your mental level of function? And then after that, to decide how much of each are you expecting or want to get back to. For your mental level of function, levels that you could think about are I want to be fully cognizant and alert and be able to do everything that I was able to do before. Or it could be that I can communicate with the person, but I might, if I lose my memory sometimes, that's okay. Uh, then it can be that I might be able to communicate, but I might not recognize people. Is that an okay quality of life for you to live? Um, some people may say that that's good enough, and some may not. Uh, it may come to the point where you're unable to communicate and unable to recognize relatives, and that may not be acceptable to you at that point or acceptable. And then there's probably the level of being comatose, of whether you're unaware of your surroundings and unable to communicate. Is that an acceptable quality of life for you? And the same goes with physical function, essentially. You want to be able to do the things you used to do, go for a run, exercise, or drive a car, go out to the movies, visit friends. Or if you are now housebound, is that acceptable to you? Or if you're now bedbound and can't get up, or you may need assistance to get up and around. And lastly, if you're bedbound and you can't even move in the bed, is that an acceptable quality of life for you? And so that might be the easiest framework of how to make decisions about what level of quality of life that you may want.
In our plan of care at Montgomery Hospice, I know we ask what is most important to our patients, and that drives all the care. Is that how we are defining how is quality of life for our patients?
Exactly, because quality of life varies, and it varies depending on what the person's situation is at that time. So, as we discussed earlier with regards to pain, some people might some people might want to tolerate a higher level of pain because they want to spend more time with their children and their grandchildren. For somebody else, it might be, I don't want any pain, whatever it takes for this pain to go away, do what I want that to be done. So it varies. But as you rightly said, at Montgomery Hospice, we ask what's important to you, because the plan of care is formulated around what's important to the person. So that translates to your Advance Directive. It's what's important to you. How do you see yourself? How would you want to be in the instance that you're unable to say what you want? What would you want to be done for you? What quality would you want for yourself?
Mm-hmm. And do we see any differences within the African American community as compared to other communities, other patients that you can mention as to what their priorities might be, or the pain tolerance, or unwanted treatment?
Statistically, African Americans do want more aggressive care and do not mind some of the pain or other suffering issues that may be involved with more aggressive treatment. So it depends on the person and the family as to what they can want to tolerate or not. But that is generally the case, and part of that goes back to the issue of trust in the medical community and being able to get the same types of therapies that other people have gotten previously.
One interesting thing with regards to that is getting the same kind of treatment that other people have received. However, it shows that African Americans get the worst kind of end of life treatment, which kind of doesn't make sense because they're not getting the other types of care that other people are getting, because they're not utilizing end of life care as much as other people, or Advance Directive as much as other people. So I guess that is one of the reasons why we want to make people aware. We want to make African Americans aware of what Advance Directive is about, what are the benefits and the burdens of life-sustaining treatment, so that they're well informed to make those decisions. And what does end-of-life care looks like? And what are the benefits and the burdens of that? So I think, us starting this discussion is really a good thing for the African American community.
Exactly, and to what Cornelia just said, on the Journal of Palliative Medicine, there's an article titled Factors Impacting Advanced Care Planning Among African Americans, Results of a Systematic Integrated Review, which was published in 2016. And the abstract, the background says African Americans are more likely to receive worse end-of-life care and less likely to participate in advanced care planning than white Americans. And one of the conclusions says consistent evidence suggests that African Americans suffer disproportionately from poor end-of-life care and are less likely to participate in advanced care planning than European Americans. Among Medicare descendants, they are also more likely to receive life-sustaining interventions, which may both a cause of poor end-of-life care and a consequence of lower participation in advanced care planning. Exactly what Cornelia said, and one of the reasons why we started doing this conversations, so that these conversations can show everyone equally the benefits and the burdens of all treatments. And as I say this, I'm thinking in this wish how comfortable I want to be. 5 Wishes mentions massage, mouth care, music, personal care, religious readings, and I know that within the African American communities, the support of their faith community is even more relevant than probably in other communities.
That is true, and usually when it is very evident that somebody is dying, most people want want to be comfortable, and that may involve, having someone from the congregation there. It might involve some music, some religious or spiritual music and reading of passages from scripture. But it the person needs to make known what they want, because even though as a community we are talking about people in a community, we have to remember that people are individuals. Some people might want privacy. Some people might want to be by themselves or just have close family members. Some people might want more people there. Some people might want it to be more of a celebration of life than grieving and mourning. So it is important for someone to state what they would want at this time, so that there would be no confusion or guessing.
Right. So our next wish is how I want people to treat me. Do I want my entire community in my bedroom when I'm bedbound, or do I want alone time? Do I want to be treated with kindness and not sadness, or do I want to die at home? Or in some communities, they don't want to die at home. Can you talk about the specifics for the African American communities?
As we have been talking about, often uh, the family can be very large or extended, and include friends and relatives, and the person may want to have many of these people present, but it's a very much an individual choice, as Cornelia was saying. And so it depends on the situation. And at other times, the healthcare team may say whether or not uh, family members or guests may be present or not, depending on the situation, because it might cause more suffering, agitation, and pain to have some family members around. Typically, most people, uh, when they are passing away, they want to be at home. That's about, surveys say that that's about 75% of people. Yet, when people are dying, oftentimes it's more, they often die in institutions. About 50% die in hospitals, and the other 25% die in nursing homes. And so there is some disconnect there. So people probably do want to be around their loved ones toward the end.
Um, so, what is the role of the faith community in honoring how people want to be treated at the end of life?
The faith community is very important to African Americans, both those who have been in America for a long time and the recent immigrants. Religion is very important. It could be it Christianity, be it Islam, whatever the religion. And the religious leaders have a lot of authority and are and are respected by the congregation. And the religious leaders support the family and the person who's ill, and this support could extend after death. So it is important for the healthcare community to collaborate with religious leaders and find out what their needs are, what specific treatments affect their religion or would have an effect on their religion, and how the healthcare community can help them to navigate those issues. Also, the healthcare leaders need to be made aware of the benefits and burdens of treatments as well, because they're the ones who would support the family, would help with family conflicts if they do arise when the decisions are not followed, or different members are not in agreement with the directives.
Right. We have a couple more minutes left. In the last wish, number 5, is what I want my loved ones to know.
Yeah, usually I suggest that they think of these four things, or say these four things to those that they consider important to them. I love you. Thank you. I forgive you, and will you forgive me? If you can deal with these four issues, that brings a lot of spiritual peace to a person and to their loved ones also that are surrounding them.
And there's been a couple of questions on the chat box about how we can guide people through this discussion. We're going to send you the link to 5 Wishes, and they have detailed questions to guide this conversation in way more detail than we have covered today. But I think we've covered a lot of territory. We're 1 minute away from closing, and if the audience has more questions, you are welcome to email them to our organizers. Final question for everybody here in the panel: is making an advance directive expensive? Does it have to be expensive?
No, there are various types of advance directives, but if you seek an attorney and have one done with them, I'm sure it costs more money. However, you can do this yourself, usually with a form like the 5 Wishes, or and have witnesses. Depending on the state, depends on the number of witnesses you may have to sign it also. Another way to do an advance directive is to actually have your physician do a MOLST form, or medical orders for life-sustaining treatment. And the other thing I should say, that would be an office visit, which may be billed for, so there may be a copay involved. So you can do this yourself. You can do it online. The state of Maryland has various resources too for this, and I'm sure we're probably going to link to something.
We have this one video that it's to a website that will guide you through a very easy advance directive that designates someone to speak for you when you are not able to, and that's the very first step. If nothing else, if you designate someone, that's going to be very helpful.
And to let them know where the advance directive is. It's not good to have it at the back of your file cabinet at the bottom drawer behind the mortgage papers.
Also, if you update your advance directives and you change your mind, and one day you wanted certain treatment because that's what seemed right, but the next you want a different one, make sure you show everyone and you tell everyone, and you have copies for everyone.
You can leave a copy with your healthcare provider. Some hospitals will keep copies of them also in your medical record.
And we're going to leave you with this video, but before we go to the video, we want to thank the audience. Thank you for the questions, and we're going to continue responding to your questions online if more questions arise. And thank you to my panelists here today. It's been a pleasure.